Welcome back to the deep dive. Today, we're opening a file that looks less like a standard medical case and more like, well, a logistical nightmare. Imagine a patient walking into a clinic, middle-aged, seems comfortable, not in any apparent distress, except for one thing.
Yeah.
He is carrying a mass on the front of his neck that measures 22 centimeters across.
To put that into perspective for you listening, just grab a ruler. 22 centimeters is, it's wider than the average human head.
Wow.
It is a massive amount of tissue to have sitting on one of the most delicate areas of the body.
Exactly. And our mission today is to unpack the journey of this specific case. We're going to move from that initial, frankly shocking visual of what's called a multinodular goiter through the detective work of the physical exam.
Which is surprisingly low tech.
Right, and then finally into the high-stakes environment of the operating room.
And high stakes is definitely the right phrase. The neck isn't just a tube connecting your head to your shoulders. It's a super highway. You have the windpipe, the esophagus, the major blood vessels feeding the brain, and the nerves that control your voice, all packed into a very, very tight cylinder.
So when you drop a mass the size of a melon into that cylinder.
Things get complicated very, very quickly.
So let's start where the doctor started, the visual. The source notes use some very specific, almost geological language to describe this thing.
They do.
They call the mass multilobulated and bossylated. Now, bossylated is a word I'd expect to find in a geology textbook, not a medical chart.
It's a fantastic descriptor though, isn't it? Boss implies a knob or a stud.
Okay.
So when a doctor writes bossylated, they aren't just trying to sound academic. They are describing a texture that feels, well, like a cobblestone street.
It's bumpy.
It's bumpy, it's irregular.
And that texture is the first big clue, isn't it? It tells you something of the history of the lump.
Hugely important. If the thyroid is smooth and uniformly enlarged, we might think of, say, Graves' disease or simple hypertrophy.
Right.
But bossylated tells us the architecture of the gland has been destroyed. It's been replaced by multiple nodule cysts, solid lumps, degenerative tissue.
So it's old.
It tells us this process has been going on for a long time. It didn't just appear overnight.
Okay, so we have this visual of a rocky landscape on the neck. The patient sits down for the local examination. The doctors perform a few specific maneuvers, and the first one seems almost too simple to be useful. They just ask him to swallow.
Simple, but it remains the gold standard. The notes confirm the swelling moved vertically. It went up when he swallowed.
Why does that happen? Is it just displacement because the throat muscles are moving?
It's anatomical tethering. The thyroid gland is wrapped in a layer of tissue called the pretracheal fascia.
Okay.
That fascia is anchored tightly to the larynx, your voice box. So when you swallow, your muscles pull the voice box up to close off the windpipe.
So you don't choke.
Exactly. And because the thyroid is strapped to the voice box, it has to go for the ride.
So if the lump sits there and just doesn't move when they swallow?
Then it's likely not the thyroid. It could be a lymph node, a dermoid cyst, a lipoma, something else entirely. But that vertical movement is the signature. It confirms we are dealing with the thyroid gland.
But then they threw a curveball. They asked him to stick out his tongue. And the notes specifically say the swelling did not move. Let me check that.
Ah, that is how you rule out a copycat. There's a condition called a thyroglossal cyst.
Okay.
It's a leftover remnant from when the thyroid migrated down the neck during embryonic development. And those cysts are connected to the base of the tongue by a tract.
Ah, so if it was that type of cyst, sticking the tongue out would physically pull the lump up.
Exactly. Tongue out, lump goes up. That's a cyst. Tongue out, lump stays put. That's the thyroid gland. It's a binary test.
Amazing.
It saves you from misdiagnosing the origin of the mass before you've even ordered a scan.
Now, there was a detail in the inspection that felt like something out of a crime novel. The doctor spotted a tiny needle puncture mark on the skin over the lump.
That is the Sherlock Holmes moment. It changes the entire context of the consultation.
Because it implies this isn't his first rodeo.
Right. It tells a clinician someone has been here before. This patient has likely already had a fine needle aspiration and FNAC at another clinic.
So he's looking for a second opinion.
Arguably, yes. Or perhaps looking for a surgeon who is actually willing to tackle a mass this big. It warns the doctor to ask for previous reports and not just start from zero.
Let's talk about what they didn't find. The report lists a lot of negatives. No stridor, no hoarseness, no tremors. Why do the experts spend so much time listing things that aren't there?
In medicine, the negatives define the urgency. Take stridor, for example. That's a high-pitched, rasping sound when breathing.
Right.
If a 22-centimeter mass is compressing the trachea, you'd expect to hear that. The fact that he doesn't have stridor means his airway is patent. It's open.
He's not an immediate emergency.
He's not. And the lack of hoarseness.
That tells us the vocal cords are okay?
They're working. It implies the mass hasn't invaded the recurrent laryngeal nerve yet. If he walked in whispering or hoarse, we'd immediately suspect an invasive cancer that's, eating into the nerves.
They also check something called Pemberton's sign. I looked this up. It looks like you're asking the patient to surrender. Arms straight up, touching the ears.
It does look like that,
Yeah.
but it's a stress test for the thoracic inlet, the opening at the top of the ribcage. If a goiter grows downwards into the chest, what we call a retrosternal goiter, it occupies that narrow space.
So when they lift their arms.
The muscles pull the mass further down into that funnel. If there's no room, the mass compresses the large veins draining the head and neck. The patient's face will turn red or blue, veins will pop out, they might get dizzy.
That's a positive Pemberton sign.
That's it. It essentially uncorks the bottle and plugs the flow.
And in this case, it was negative. So lucky for the surgeon, the mass is mostly sitting out in the open.
Exactly. It means they likely won't have to crack the sternum, the breastbone, to get it out.
So combining all these physical clues, it moves with swallowing, it's bossylated, it's huge, but it's not crushing the airway or the veins. The provisional diagnosis is a non-toxic multinodular goiter.
Non-toxic is the key here. It means the engine isn't revving too high. He isn't hyperthyroid.
But here's where I want to push back a bit. The notes say they suspect it's benign because it's not hard and not fixed to the skin. But can you really trust that? With a mass this big, 22 centimeters, isn't there a huge risk that something nasty is hiding in the middle of it?
You are hitting on the central dilemma of goiters. You can never be 100% sure just by feeling it. Yes, the signs point to benign mobility, lack of pain, slow growth, but the differential diagnosis, the list of suspects, must include malignancy.
The source lists a few scary ones. Papillary carcinoma, follicular carcinoma.
Those are the differentiated cancers. They're common but usually treatable. The one that keeps surgeons awake at night is anaplastic carcinoma.
Why is that one different?
It's one of the most aggressive cancers in the human body. It grows so rapidly, turning a goiter into a rock-hard, fixed mass that just strangles the airway in weeks.
Wow.
Fortunately, our patient's mass is mobile and non-tender, which makes anaplastic highly unlikely, but you have to prove it.
So to move from unlikely to certain, we have to look inside. The investigation phase. The source material outlines a multimodal strategy. It seems like they attack this from three angles: function, structure, and pathology.
Correct. You cannot rely on just one. Function is simple, blood work, TSH, T3, T4. We need to know if the gland is overproducing hormone, because operating on a toxic thyroid can trigger a life-threatening storm of hormones during surgery.
Right, you have to cool the engine down before you take it apart.
Exactly. Then the structural map comes from the ultrasound. The notes call it the cornerstone.
I always assumed a CT scan would be better. Why is ultrasound the go-to?
Ultrasound is actually superior for looking at the thyroid's internal texture. It allows us to use the TIRAD scoring system.
TIRADS. We love an acronym. Break that down for us. Does it just tell you how big the lumps are?
It's much more nuanced. It stands for Thyroid Imaging Reporting and Data System. It scores every single nodule based on suspicious features.
I like what?
Is it solid or fluid-filled? Are the edges smooth or jagged? Does it have microcalcifications, these tiny specks of calcium?
And microcalcifications are bad.
They are a red flag for papillary carcinoma. So, TIRADS gives us a risk score. If a nodule scores high, we don't just watch it. We stick a needle in it.
That's the FNAC fine needle aspiration cytology.
Right. But here's the nuance. We don't just poke randomly. We use the ultrasound to guide the needle into the dominant or most suspicious nodule.
Okay.
We suck out a few cells and send them to a pathologist.
Who then uses another scoring system, the Bethesda system.
Medicine loves classification. Yes, the Bethesda system. It tells the surgeon what to do next. Bethesda 1 is non-diagnostic, try again. Bethesda 2 is benign, relax. Bethesda 6 is malignant, operate immediately.
What about the ones in the middle?
That's the gray zone. Bethesda 3 and 4 are indeterminate. The cells look weird, but not definitely cancer. That used to be a huge problem.
Because you'd have to operate just to find out.
You would. We'll get to how they solve that problem now with genetics later, but I want to go back to the imaging. The doctors did order a CT scan for this patient. You said ultrasound was better, so why expose him to the radiation of a CT?
Yeah, why both?
Remember the size, 22 centimeters. Ultrasound is great for detail, but it has terrible depth perception. It can't see behind bone. The CT scan is the roadmap for the surgeon. We need to know, is the trachea shifted to the left or right? Is the goiter wrapping around the esophagus?
It's like checking the blueprints before you knock down a wall.
Precisely. You do not want to find out the anatomy is distorted after you've made your incision.
Which brings us to the main event, the solution. The decision was made to perform a total thyroidectomy. Why take the whole thing? If he has lumps on one side, why not just do a hemithyroidectomy and leave him with half a gland?
That is a valid strategy for small, single nodules. But for a multinodular goiter, the entire gland is usually genetically prone to forming these lumps.
I see.
If you leave half, there is a very high probability, some studies say up to 40%, that the remaining half will grow a goiter in 5 or 10 years.
And I'm guessing going back for a second surgery isn't as easy as the first one?
It's a nightmare. We call it reoperative thyroid surgery. The normal anatomical planes are just gone, replaced by scar tissue. The nerves are stuck in the scar.
Oh, wow.
The risk of permanent injury goes through the roof. So for a big M&G, you take it all out the first time, one and done.
Let's talk about those risks. The surgical minefield. I knew the neck was crowded, but the deep dive notes highlight some very specific, very tiny structures that can cause catastrophic problems.
The most famous one is the recurrent laryngeal nerve, the RLN. It controls your vocal cords.
And it runs right next to the thyroid.
It's worse than that. It runs in the groove between the windpipe and the esophagus, often intertwined with the thyroid's blood vessels. To remove the gland, you have to very carefully separate it from this nerve.
And if you snip it,
If you cut one, the patient has a hoarse, breathy voice forever. But if you injure both, which is a disaster, both vocal cords can paralyze in the closed position.
so they can't breathe.
The patient can't breathe. They need a tracheostomy, a hole in the neck, just to survive.
That's terrifying.
It is. And that's why the notes mention IONM intraoperative nerve monitoring. It's a special tube placed in the airway with electrodes that touch the vocal cords.
Okay.
The surgeon uses a probe to test tissues before cutting. If the probe touches the nerve, the machine beeps loudly. It helps map the nerve's location in real time.
There's another nerve mentioned, the superior laryngeal nerve. The notes say injury here causes voice fatigue. That sounds, minor compared to not breathing.
It sounds minor unless you are a singer or a teacher. This nerve controls the tension of the vocal cords. Without it, you can't hit high notes, and you can't project your voice. You lose your range.
The other big risk involves the parathyroid glands. I had to read this section twice. We have 4 tiny glands the size of rice grains that control all our calcium.
Yes, and they often sit right on the back capsule of the thyroid. They are incredibly difficult to see, and they share the same blood supply as the thyroid.
So when you remove the thyroid, you risk stripping them of their blood flow.
Exactly. And if that happens, the patient's calcium drops. They get tingling in their fingers, muscle cramps, and in severe cases, seizures.
The notes describe a salvage technique called autotransplantation. It sounded like science fiction to me. You take the dying gland and just plant it somewhere else.
It's biological recycling. If the surgeon sees a parathyroid gland turning dark, meaning it's losing blood, they remove it, mince it into tiny pieces, and tuck those pieces into a pocket in the sternocleidomastoid muscle in the neck.
And it just takes root.
It acts like a skin graft. It grows new blood vessels from the muscle, and after a few weeks, it starts pumping out parathyroid hormone again. It's a brilliant, simple way to prevent permanent disability.
So the surgeon navigates the nerves, saves the rice grain glands, and removes the 22 centimeter mass through a Kocher's collar incision.
Which is designed to hide the scar in a natural skin crease. The cosmetic outcome matters.
The patient wakes up, the mass is gone. But the danger isn't over. The notes highlight an immediate post-op risk, hematoma. Why is a little bleeding so dangerous in the neck?
It's about physics. The neck is a tightly packed cylinder. If an artery pops open after the skin is stitched shut, that blood has nowhere to go.
Oh.
It fills the space rapidly and pushes the trachea flat.
It suffocates them from the inside.
Yes, it is a true surgical emergency. The notes mention keeping a tray for emergency decompression at the bedside. That means the team must be ready to grab a scalpel and cut the stitches open right there in the recovery room to release the pressure.
Assuming that doesn't happen, the patient goes home. But their life has changed. We've cured the goiter, but we've removed their metabolism engine.
That's the trade-off. They are now hypothyroid by definition. They will need to take a thyroxine pill every single morning for the rest of their life.
Before we wrap up, the source material touched on some future tech. We mentioned those indeterminate biopsies earlier. How is technology solving that gray area?
Molecular diagnostics. Instead of just looking at the shape of the cells, we can now extract DNA from them. We test for specific genetic mutations like BRAF or RAS.
So the genes tell you if it's cancer.
Basically, if we find a high-risk mutation, we operate. If the genetic profile is clean, we can safely watch and wait, sparing the patient surgery.
It's moving from I think this looks bad to I know this is bad.
Exactly.
And for the people concerned about the scar, especially if they don't have a massive 22 centimeter goiter, the notes mention robots.
Robotic and endoscopic surgery, yeah. We can now remove the thyroid through incisions in the armpit or even through the inside of the mouth, the transoral approach.
So literally no visible scar on the neck.
None. It's technically demanding, but for the right patient, it's a game changer cosmetically.
We've covered a lot of ground. From the geology of a bossylated neck to the microscopic analysis of genes, what is the one thing you want our listener to take away from this case?
I think it's the concept of the multimodal safety net. In complex medicine, you never trust just one source of information. The physical exam told us it was a thyroid, the ultrasound told us the structure, the biopsy told us the pathology, the CT told us the anatomy.
If you skip one, you fall through the net.
Exactly. It's the synthesis of all these layers that makes the surgery safe.
My takeaway is a bit more philosophical. We call this a success. The mass is out, the risk of cancer is zero. But I can't help but think about the trade. We traded a physical burden for a medical dependence.
It is a profound shift. The patient is no longer ill with a goiter, but they are now a patient forever, tethered to a pharmacy.
It forces us to ask, is a cure the restoration of the body to its original state, or is it simply the successful management of a new normal?
In modern medicine, it is almost always the latter. We solve the acute threat, but the price is often chronic maintenance.
A fascinating price to pay for a clear neck. That's it for this deep dive into the world of multinodular goiters. Thanks for listening.
Thank you.